Good afternoon to the colleagues connected from Italy and good morning to the colleagues connected from the United States. For people not present at the previous meeting, I will introduce myself again. I'm Giuseppe Lorusso, I'm a medical oncologist, and I work at the thoracic unit of the Istituto Nazionale dei Tumori of Milan in Italy. It is a great pleasure to be here today and to introduce the second meeting of our conference. The previous meeting was a success, both for the high quality of the presentation and for the high number of people connected. I think this meeting will also keep the same level of quality. Also today, the meeting will last 2 hours. Today, the speakers will make an overview on the role of immunotherapy treatments in patients with non-oncogene-addicted non-small cell lung cancer. Dr. Agarwal will talk about old and new biomarkers for immunotherapy. Dr. Reck and Dr. Garassino will report news about immunotherapy as monotherapy or as a combo. Finally, Roberto Ferrara will discuss mechanisms of HPD in patients treated with immunotherapy. So, let me introduce my chief, Professor Filippo De Bro. Professor Filippo De Bro is the head of Oncology and Hematology Unit Department at the Istituto Nazionale dei Tumori of Milan in Italy. Professor De Bro, you have the floor.
Hi to everyone. Good evening. I just have to say my compliments for the meeting and the organization of the meeting because the topics are very interesting and also the sequence of the topics presented in the 3 sessions are very rational. Today, I guess, is the more challenging session because we have a lot of topics to discuss. For example, if we really need combo immunotherapy and chemo for high PD-L1 grade tumors, what to do when a patient cannot afford to be treated with immunotherapy and does not have any oncogene addiction, and so on. So I guess it's going to be very interesting, either the presentation and the round table at the end of the presentation. And I don't want to spend more time because I guess we will use the time for the discussion and for the questions and for the round table. So thank you to everyone, for the participants. It's a pleasure for me to see again Marina. That is a while that we are not talking to each other since she left. We're both very, very busy and involved, but there is a strong relationship together and with the group. And so I'm very proud that she's still cooperating, and I hope that this cooperation will transform in a back work together in the next future.
Thanks, Professor De Bro. Let me introduce you my colleagues that will be the chairs of the second meeting. Dr. Marta Brambilla and Dr. Alessandro De Toma. They both will work with me and the thoracic unit of the Istituto Nazionale dei Tumori of Milan. Marta, you have the floor.
Good evening to everyone. I would like to thank you, Giuseppe, for the opportunity to participate to this amazing conference. It's such a pleasure to be here among these excellent experts in this field. First of all, I would like to make a quick reminder in the program of the conference. We will listen to 4 presentations of 20 minutes each. At the end of the last presentation, we will all join a round table in which all the audience is kindly invited to ask questions to the experts from the online forum. Let's start with the first presentation. First speaker is Professor Charu Agarwal from the University of Pennsylvania. She is a Professor Associate for the Lung Cancer Excellence, and she will shed some lights in the complex fields of biomarkers in immunotherapy. Professor Agarwal, welcome.
Thank you to the organizers for giving me an opportunity to speak today. I would I'm going to talk to you about old and new biomarkers for immunotherapy. These are my disclosures. We've come a long way in management of patients with metastatic non-small cell lung cancer. Today, at least in the United States, we have many different options for management of patients with non-oncogene addicted metastatic non-small cell lung cancer. Here is a summary of approvals that have come about incorporating either immunomonotherapy or combination immunotherapy agents, as well as combination chemoimmunotherapy. You can see this is a very expansive list that goes from October of 2016, where we saw the first approval of pembrolizumab with the clinical trial of Keynote-24. And most recently, we saw data from Checkmate 9LA, which is at the very bottom, where we saw improvement in overall survival with the use of chemotherapy along with nivolumab and ipilimumab, ushering in an era of combined quadruplet therapy. And we've really made a significant difference in terms of immunotherapy and outcomes in patients with non-small cell lung cancer. This is a representation from a paper that was published by Dr. Friedlander and colleagues, where you can see different clinical trials leading to different outcomes here in terms of overall survival. And you can see that we are beginning to find a tail to the curve, regardless of any regimen that we come in with. And it's no surprise that today, overall survival with metastatic non-small cell lung cancer, 5-year overall survival is no longer less than 5%, but we are in the 25 to 35% range, again, based on certain biomarkers that I will talk to you about. So when we think about biomarkers for immunotherapy, they can be categorized into some currently used biomarkers, as well as some that are investigational, under research, as well as being potentially explored. Right on the top, you'll see two different biomarkers that have been looked at extensively in phase 3 clinical trials. One of them is tumor mutational burden. It's been looked at as a potential biomarker for several different cancer types and has been looked at in both blood and tissue. And I'll talk a little bit more about it in my talk. But I wanted to start off with PD-L1 expression and how it serves as a predictive biomarker for immunotherapy response. Some of us will consider this as an old biomarker. And there are certain new biomarkers that are being evaluated. These include things such as HLA class 1 diversity, or LOH, at HLA class 1 alleles, which really look at the tumor microenvironment. But we're also beginning to evaluate mutations, not just in the beta-catenin pathway listed here at the bottom, but also mutations in the JAK2 or STIC11, which may actually lead to differential outcomes when it relates to chemoimmunotherapy or immunotherapy alone. So before we jump on to some of the emerging biomarkers, I would like to talk about PD-L1 expression on tumor cells. PD-L1 expression has shown to correlate with clinical benefit to immunotherapy. While it's not a perfect biomarker, it's something that we use routinely. And in fact, many of our approvals in non-small cell lung cancer are contingent on PD-L1 expression on tumor cells. The Blueprint project evaluated comparability, if you will, of different assays. There is not one standard assay. There have been several different antibodies that have been used. And the Blueprint project 1 and 2 both looked at evaluating whether or not we can come up with a homogeneous way of classifying or using these antibodies interchangeably. So on the left, you will see that the Blueprint project demonstrated that the 22C3 antibody is equivalent to the 28-8 as well as SP263. However, the SP142 was maybe an outlier. Now, there are some problems or potential disadvantages with PD-L1 expression. I would say that PD-L1 expression is variable. It has been demonstrated to have variable expression based on the organ, based on the metastatic site. It is quite heterogeneous, and depending on which site has been chosen for a tissue biopsy, it may lead to variability in terms of expression of PD-L1. It is also a dynamic and an inducible marker. And lastly, it's subjective. There is a variable amount of inter-observer variability that we can find with PD-L1 expression. On the right, you can see that the inter-observer variability between some of the common assays, such as 22C3, 28.8, and SP263, may actually be okay. There's not that much variability. However, I have circled for you some of the observations. Now, each individual dot represents the PD-L1 expression as measured by a pathologist on that particular sample. And you can see there is not a lot of correlation with the dots in the blue, which is the 7310 antibody, as well as the dots in the green, which is the SP142 antibody. So what do we learn from this? That PD-L1 expression using any of the antibodies other than SP142, we can pretty much interchangeably look at the data. So based on improvements with single-agent immunotherapy versus chemotherapy, we now have 3 approved agents for patients with PD-L1 greater than or equal to 50%. And this has come about from trials such as KEYNOTE-24, looking at pembrolizumab, Empower 110, looking at atezolizumab, and most recently, Empower 1, looking at cemiplimab, again, emphasizing that PD-L1, when it's more than 50%, can be used as a predictive biomarker. We know that these patients will benefit compared to chemotherapy. But how about PD-L1 less than 50%? It does not necessarily predict for benefit from IO monotherapy versus chemotherapy. So for this group of patients in the 1 to 49% group, we can't really say that PD-L1 is giving us a lot of information, or we can't confidently say that IO will improve outcomes. And then response, PFS, and OS benefit after chemoimmunotherapy also depend on PD-L1 expression level. And this has been demonstrated both in the KEYNOTE-189 trial evaluating chemoimmunotherapy, as well as KEYNOTE-407, which I have not demonstrated here in the squamous setting. On the left, you will see data from the TPS 1 to 49% category for patients that receive immunotherapy alone in KEYNOTE-42. Additionally, there seems to be a linear relationship with outcomes. Retrospective data, as demonstrated on the left, have demonstrated that PD-L1 expression as it goes up seems to correlate with improved response rate and improved overall survival. Patients with PD-L1 90% to 100% seem to have
We have some problem with the connection, so we will try to represent it.
Can you hear me?
Okay.
Okay,
yes.
okay.
Sorry about that. On the right-hand side, you can see that in a prospective trial, we also saw that higher PD-L1 level here, PD-L1 greater than 90%, seem to have the most significant responses. And the bar graphs also demonstrate the different quartiles between 50 to 100%, giving us differential response rates here. So in summary, for PD-L1, I will say that while it's an imperfect biomarker, it does provide us information. If we have a patient with PD-L1 greater than equal to 50%, we can confidently say that they will benefit from immunotherapy compared to chemotherapy. The same may not be true for 1 to 49. But again, I think PD-L1 is one of the biomarkers we use in clinic routinely to help us decide whether or not to proceed with immunotherapy alone or combination chemoimmunotherapy. Moving on to tumor mutational. Tumor mutational burden is a representation of the number of mutations that may be present that may lead to increased neoantigen exposure. On this chart, you will fall towards the right side of the chart, really expressing higher number of mutations and higher overall mutational burden. And it's no surprise that these are the cancers that led to a significant approvals in immunotherapy. Response to immunotherapy does correlate with tumor mutational burden. This is now an old paper from 2015, where Dr. Rizvi and colleagues demonstrated that higher tumor mutational burden was associated with improved outcomes. Your PFS outcomes in non-small cell lung cancer have been demonstrated on the right after treatment with anti-PD-1. And on the left, we see improvement in overall survival in patients with higher tumor mutational burden, melanoma. Sorry. We've also seen this in clinical trials in non-small cell lung cancer prospectively. This is results of nivolumab versus chemotherapy from the Checkmate 026 study that evaluated high TMB patients, where you can see that the PFS was much higher at a hazard ratio of 0.62. And the same benefit was actually not seen in patients with low or medium tumor mutational burden, with a hazard ratio of 1.82. And in fact, chemotherapy seemed to have a higher proportion of patients that benefited, at least in terms of progression-free survival. When we use combination immunotherapy with nivolumab and ipilimumab, we do see similar trends. This prospective analysis from the Checkmate 227 that was presented at the ASCO annual meeting a few years ago. On the left, you will see patients with TMB higher than equal to 10 mutations per megabase seem to have improvement in PFS compared to chemotherapy alone when they receive both nivo and ipi, or nivolumab plus chemotherapy. But the same wasn't true for patients that had less than 10 mutations per megabase. And I think this is intriguing data to suggest that TMB and PD-L1 could be comprehensively used for prediction of response. Well, while we've shown you evidence with tissue TMB, we have to recognize that tissue TMB is very difficult to assess on an ongoing basis. Even on the best clinical trials, we have only been able to assess it for 40% or so of the patients, just because of the tissue requirements, as well as the complexity of the assay itself. Plasma TMB has been used successfully, and here I have two examples for you. One is on the left, which is a paper that was published in Nature Medicine evaluating blood TMB using the Foundation Medicine assay. Here, Dr. Gandara and colleagues demonstrated that blood TMB greater than equal to 16 can select out patients that will benefit from single-agent immunotherapy. On the right is data from Dr. Peters and Dr. Rizvi from the MYSTIC trial, where we know that patients using Ardent Omni assay, patients with a blood TMB of greater than 16, or even if you refine further with a blood TMB of greater than 20, we can identify a subset of patients that may benefit from immunotherapy compared to chemotherapy. Can we use this in patients with chemoimmunotherapy? We evaluated our own cohort of patients at Penn and evaluated whether or not using a cutoff of 16 mutations per megabase, could we differentiate patients with a higher TMB that may benefit from immunomonotherapy as depicted in the center, or chemoimmunotherapy as depicted on the right? And although we had a very small data set, about 67 patients, I will say that we did find improvements in both progression-free survival and overall survival when using chemoimmunotherapy as well as pembro monotherapy. We were able to demonstrate that blood TMB is very similar to tissue TMB. And also, lastly, I will say that while these results are intriguing, they have not actually been validated in some of the studies that were conducted by Dr. Garasino using samples from Note 189 study. So I think this remains an open question. But what's important is that I think we should not stop at TMB alone. We should take this a step further. And in our analysis, we used a composite score. We evaluated patients with negative predictor mutations, such as STIC11, KEEP, and we combined these with TMB. And when we use this composite score above on the Kaplan-Meier curves, you can see that patients who had these negative predictor mutations and had low TMB did clearly poorly compared to patients that did not have these mutations and had a high TMB. On the left, you can see our chart here, which combines response rate data as well as individual mutations. And for patients that seem to have these negative predictor mutations, we can find that they tend to bunch together with either progressive disease or minimal response to immunotherapy, again suggesting that this may be a new biomarker, not just using TMB, but using a combination of different approaches to predict response. What about TMB itself in the tumor, and what do we know about data using, data from clinical trials? So here is monotherapy trials, so Keynote 1, as well as you will see the other trials with single agent immunotherapy, such as Birch and Fir using atezolizumab, and the BFIRST trial, which is a prospective trial. And you will see that most of these studies will demonstrate a benefit when it is TMB high. What happens when we look at other studies for combination chemoimmunotherapy or combination immunotherapy, and that's demonstrated on the next slide here. Sorry, one more. So if we look at trials looking at randomized immunotherapy versus chemotherapy trials, we see that using TMB, there is some differentiation in PFS on the left. So you can see that most of the trials fall towards the left, favoring immunotherapy. However, there doesn't seem to be a clear differentiation when we look at overall survival on the right. You can see that most of these trials are crossing that, crossing the middle bar, which is 1. And if we look at the next slide, which is evaluating chemoimmunotherapy, we see that clearly there's no difference in PFS or OS for these trials using tissue TMB. So really, I think what I've discussed with you is that PD-L1 is a validated biomarker, which is going to be very useful in clinic, but it has its shortcomings. Second thing we talked about was TMB and how the data is sort of all over the place at this point in time, but we have found a nice way to look for TMB using blood and plasma, and that may provide a window into the future by using a combination of different approaches. I want to spend a little bit of time in terms of composite biomarkers. This is a very nice paper from Science that was published a few years ago, where different biomarkers incorporating not just TMB, but gene expression profiling and T-cell signatures were incorporated, and patients with solid tumors into 4 different quadrants based on T-cell, GEP profile on the x-axis and tumor mutational burden on the y-axis. And the high, which is in this quadrant here that I'm pointing out, tend to be the ones that are most responsive to immunotherapy. Here you can see immunotherapy responses of about 37% against single agent. But we are also beginning to identify the opposite, which is low GEP and low TMB, which tend to represent the immune desert and almost have no responses. Here, 0% response rate seen. And I think we eventually need to move to a place where we try to identify these patients, because they have different biology, they have different outcomes, and they may need different strategies. So we may say that patients with a more stromal cellular type or the tumor microenvironment may need a completely different approach as opposed to patients that may be immunologically hot. Having said that, we also know that plasma NGS has been used to serially monitor patients while on targeted therapy. But can we use this approach to work in patients without targetable mutation? Here are some of the examples from some of our earlier work demonstrating that allelic fraction of a particular biomarker can decrease or increase depending on radiographic response. We utilize the same approach and ask the question, can serial monitoring of patients on immunotherapy with ctDNA serve as a predictive biomarker? We enrolled patients with treatment-naive stage 4 non-small cell lung cancer that was starting pembrolizumab-based therapy, and we collected blood at baseline as well as at 9 weeks. And we looked at the primary endpoint of association between molecular response, as defined by change in ctDNA over time, and radiologic response. Our secondary endpoints were association between molecular response and duration of therapy, as well as association between molecular response and PFS and overall survival. So it's a prospective study that we performed at the University of Pennsylvania. And here are some of the data that we found as our results. Sorry, there is a delay here. Could you move to the next slide? I'm sorry, I'm unable to move from my transponder here.
Have to.
Sorry, can you hear me?
Yep. Yeah.
All right, sorry. So I'm back here. So what we showed was that a change in variant allele fraction did predict for both progression-free survival and overall survival after pembrolizumab-based therapy. On the top, you will see progression-free survival in patients that seemed, you can see that molecular responders seem to have a much better progression-free survival as well as overall survival on the right. And at the bottom, we did include some patients that had complete clearance of their ctDNA at the 9-week time point, and you can see their PFS and overall survival was actually much better. Again, consistent with, can we pick up ctDNA responders or molecular responders even before radiographic progression, I think is the next question. So in conclusions, I think biomarkers for response to immunotherapy are key. As I discussed with you, PD-L1 is an established biomarker for prediction of response to PD-1 and PD-L1 therapy. Tumor PD-L1 correlates with overall response rate, PFS, and OS. Tumor mutational burden predicts for overall response rate, PFS, however, does not have a clear role as a single biomarker at this time. Blood-based TMB is complementary to tissue-based TMB. At this point, we know that PD-L1 and TMB are independent biomarkers, and then future efforts will focus on combination biomarkers. And with that, I'd like to conclude my presentation and thank the organizers for inviting me again, and I'm happy to take any questions towards the end. Thank you.
presentation we will see on the round table. Now I'm very pleased to introduce Professor Martin Reck from the Department of Oncology of Langen Clinic in Germany. Professor Reck will talk us about IO monotherapy and his perspective and new data about this in this setting. We hope he will not fight against Marina Garcina at the end of this discussion. Please, Professor Reck.
Never. And thank you for the kind invitation to be in Milano, at least virtually. And it's a pleasure to talk to you about immunotherapy, in particular to talk about IO monotherapy. And it's true that we already had some discussions about the role, and the title of my talk has been a bit provocative. Is there still a role for IO monotherapy? And I've got the liberty to add just the question, why not? And I'm happy to talk about the new data that we have seen for IO monotherapy in patients with advanced non-small cell lung cancer. These are my disclosures. And when we talk about lung cancer, we are aware of the facts that still we have the problem that the majority of our patients are diagnosed with an advanced stage of disease. The majority of our patients are not resectable. The prognosis is poor. And I also have to say that the majority of Caucasian patients is diagnosed without any treatable oncogenic alterations, which means that the majority of patients that we do see every day in our centers, in our hospitals, is in need of a palliative systemic therapy. So I think when we talk about systemic therapy, quality of life and tolerability and the maintenance of quality of life in this palliative situation is something which is a key endpoint in all of our studies that we have to perform or that we performed in the past. Well, what we also have seen, and just excuse me, I try to go to the next slide, is that immunotherapy really has been a game changer in management of our patients with advanced non-small cell lung cancer. And we started in patients with pre-treated non-small cell lung cancer. We have seen in 4 randomized trials a significant improvement in overall survival. We have seen a sustainable improvement in overall survival, favoring the use of the checkpoint inhibitors. And now we are using these new opportunities also in first line, either alone as monotherapy or in combination with chemotherapy. But what we also have seen, we are treating patients much longer with the immunotherapy compared to chemotherapy. Patients are receiving immunotherapy for 2 years or longer, and therefore the topic of tolerability of the therapy is very, very important. So what perspectives do we have when we talk about monotherapy? And first of all, we do have a chance of a chemotherapy-free systemic treatment. And together with that, we have the chance of improved tolerability, which is the same like a reduction of treatment-limiting adverse events. We have a chance of improved long-term tolerability, and we have the chance to improve the maintenance of the patient's health status in a palliative treatment setting. And I think this is a great perspective which we can offer to our patients. However, the selection of the appropriate patients for the monotherapy will be key. Well, we need a biomarker, and Charu just gave an excellent overview on the situation of biomarkers in selection for immunotherapies, monotherapies, combination therapies. I think at the end of the day, the most valid marker still is the PD-L1 expression, and here is one of the very first publication showing the clear correlation between the PD-L1 expression and the efficacy of the checkpoint inhibitor pembrolizumab. And I think this has been the cornerstone of all trials which have been opened thereafter. And when we look on the trials, we can say that we have now 3 randomized trials investigating a monotherapy of a checkpoint inhibitor compared to a platinum-based chemotherapy in patients with advanced non-small cell lung cancer without oncogenic alterations. We have the Keynote 024, which was the first trial looking on pembrolizumab compared to platinum-based chemotherapy with the original primary endpoint of progression-free survival and the opportunity of crossover in the control arm at time of progression. We have the IMpower 110 investigating the anti-PD-L1 antibody atezolizumab compared to platinum-based chemotherapy with a primary endpoint of overall survival without the opportunity of crossover. And we have the recently published IMpower Lung 1 trial investigating a new anti-PD-1 antibody cemiplimab compared to platinum-based chemotherapy, again looking on overall survival, again having the opportunity of crossover, and also offering a quite interesting post-progressive approach for the patients who were randomized to cemiplimab with the opportunity of adding chemotherapy to cemiplimab at the situation of progression. Well, when we look on the results, and I'm focusing here on the results on overall survival, the data have been very consistent. So in each of the trials, we have seen a significant improvement or a significant prolongation of overall survival favoring the IO monotherapy compared to platinum-based chemotherapy. And when we look on trials where we have some more follow-up available, and Keynote 024 has been one of these trials where we have been able to present the 5-year efficacy data. We also have seen a consistent improvement in efficacy favoring the checkpoint inhibitor compared to chemotherapy alone. On the right side, you can see the consistent signal for the primary endpoint progression-free survival with a hazard ratio of 0.5. This has been exactly the hazard ratio which we have observed at the time of the first presentation. And on the left side, you can see the consistent benefit in overall survival favoring the treatment with pembrolizumab compared to chemotherapy with a hazard ratio of 0.62, with a doubling of the 5-year overall survival rate from 16% up to 32%, despite the crossover, which has been observed in 66% of the patients. And I think these are very strong signals supporting the role of the IO monotherapy. Well, looking on tolerability, and this is Keynote 024 as an example, we have seen quite consistent benefit in tolerability favoring the monotherapy. We have seen a reduction in the incidence of treatment-related adverse events, in particular when we look on the clinically relevant grade 3 to 4 or grade 3 to 5 adverse events. And even when we look on the group of patients who had received the immunotherapy for a long time, and in Keynote 024, 39 patients received pembrolizumab for up to 2 years, there was no aggravation of the treatment-related toxicity. There was also no aggravation of the treatment-related immune-related adverse events, which means that tolerability remains to be in favor of the immunomonotherapy, even with a long treatment duration over 2 years or longer. Well, the confirmation of these findings has been done by Roberto Ferrara and his colleagues, who took all the data that were generated together in a Cochrane analysis. And I think this is the evidence of the highest level which is available when we have this meta-analysis level. And when we look on all trial data that have been generated so far, we have a very clear signal in improvement of overall survival favoring the IO monotherapy compared to platinum-based chemotherapy in the group of patients with high PD-L1 expression, more than 50%. There, indeed, we do see a hazard ratio of 0.68 and a p-value of less than 0.00001. Interestingly, and Charu Agrawal talked about this, the signal is a bit more difficult when we look on TMB as a predictive marker, as a selection marker. Overall, when we look on the trial data that have been generated, we have seen some signal in progression-free survival. However, we are still missing a clear selection benefit for overall survival in patients selected according to TMB for the IO monotherapy compared to chemotherapy. And also when we talk about tolerability, the signal has been quite clear that in the group of patients who had received the monotherapy, the incidence rate of treatment-related adverse events was lower compared to the group of patients who had received the chemotherapy. In all the trials that have been included in this meta-analysis, the rate of grade 5 toxicities was quite low in both of the arms. But when we look on the treatment-related adverse events, grade 3 to 4, and these represent already clinically relevant treatment-related adverse events, as mentioned before, the tolerability was clearly in favor of the patients who had received IO monotherapy. The risk ratio was 0.43, and again, the p-value was highly statistically significant in favor of the IO monotherapy. Do we have special populations which might benefit more from this IO monotherapy? And I would like to talk a little bit about two groups of patients. Number one is the group of patients with, I would say, the difficult non-small cell lung cancer. This is the group of patients with squamous cell non-small cell lung cancer. And we do know that these are patients who are normally heavy smokers. The smoking habit is more dominant in the group of patients with squamous cell non-small cell lung cancer. And we also do see that related to the strong addiction to smoking, we do see more comorbidities in patients with squamous cell non-small cell lung cancer. We do see more pulmonary disorders, chronic pulmonary diseases. We do see more cardiovascular disorders in this group of patients. And overall, we also do see a more unfavorable prognosis in the group of patients with advanced squamous cell non-small cell lung cancer. And when we come back from our history of chemotherapy overall, the achievements that we could generate in patients with squamous cell non-small cell lung cancer always have been below the achievements that we have seen in patients with non-squamous non-small cell lung cancer. So what are the data that we have seen for immunotherapy, in particular when we talk about this group of patients who have been included in the IO monotherapy trials? And the signal has been quite consistent in all the randomized phase 3 trials when we look on the KEYNOTE-024 trial, but also when we look on the Empower 110 or the Empower Lung 1. In each of the trial, the benefit for the IO monotherapy has been at least comparable to the benefit that has been generated in the group of patients with non-squamous histology. In some of these trials, we already have seen a more pronounced benefit in overall survival favoring the monotherapy compared to chemotherapy. And the second group of patients is the group of patients with brain metastasis. And I have to say that in the trials which I am able to present, the majority of patients or patients only were allowed to enter the trial when they had pre-treated brain metastasis. And of course, it would be of interest to see also data in patients with untreated brain metastasis, but we have to work with the data that are available. Well, when we look on efficacy data in patients with pre-treated brain metastasis, we have a growing evidence that immunotherapy and also immunomonotherapy seems to work also in this group of patients, with an unfavorable prognosis. So this is a pooled analysis looking on the monotherapy data in several trials with pembrolizumab compared to chemotherapy, focusing on this group of patients with pre-treated brain metastasis. And the signal of efficacy also was very clear when we look on the different endpoints of efficacy in this group of patients with pre-treated brain metastasis. And also very recently, we have seen in the Empower Lung 1 trial that also in the group of patients with pre-treated brain metastasis, there was a clear benefit for cemiplimab compared to platinum-based chemotherapy. We do see this when we look on the response rate 41% compared to 8.8% in the chemotherapy arm. But we also do see this when we look on the primary endpoint, when we look on overall survival. We do see a prolongation of the median overall survival from 11.7 months up to 19 months. And this is corresponding to a hazard ratio of 0.17, which is an amazing signal. We have to be careful. This is a retrospective exploratory analysis, but at least we may say that there is no decreased effect of the immunotherapy in this group of patients. Well, the question is, how does these data compare to chemotherapy IO combinations? And I think this has been the battlefield with Marina, and we have to say that we are still lacking prospective randomized trials. And it's very difficult to see trials or to generate trials in this field. The question is extremely important, but I think we will not see any pharmaceutical industry supporting this trial. So this will be a purely academic approach to generate prospective evidence on these important questions. Currently, we have 2 trials going on investigating this question. Number one is the PERSEE trial, which is a French trial, and we have the Insignia trial, which is a US trial, which is addressing this prospective question of immunotherapy versus immunochemotherapy in this particular group of patients with high PD-1 expression. So what we can do today is something which normally is not allowed. We only can look on cross-trial comparisons, and I would like to thank Lisa Hendricks for giving me this slide, and she summarized all the survival results which are available right now for the different IO monotherapy trials, but also for the different combination trials. And when you look on the 2-year survival rates, in particular in the group of patients with high PD-1 expression, you can see that it appears to be at least comparable. When we look on the 2-year survival rates, we do see a 2-year survival rates, which is roughly in the range between 45 and 52%. So at least from this non-allowed perspective, there doesn't seem to be a huge difference whether the patient does receive the monotherapy or the combination of chemotherapy with a checkpoint inhibitor. Another way to look on this question is to look on real-world data. And this has been presented by Solange Peters on one of the ESMO plenary sessions. And you can see this on the left side. And this is based on Flatiron records on individual patient data, looking on the survival of IO only compared to the combination of chemo and IO. And when you look on the overall survival, you can see that there isn't a real difference in survival between the 2 groups. There is a difference when you look on the group of patients with a PD-1 expression of 1 to 48%, 5 to 49%. These are the curves on the right side. This is an FDA analysis which has been presented on a number of trial data at the ASCO meeting this year. So there is a strong signal for the monotherapy, and I think there's a substantial group of patients who might benefit from this monotherapy when they do present with a high PD-1 expression on the tumor cells, but there might be some populations where we have to be a bit cautious. And one of the populations where we really have to be a bit cautious is the group of patients who are clearly never smokers. So when we look on these patients in the different trials, when we look on Keynote 024, 042, or Empower 110, in none of these trials, there was a benefit for the monotherapy compared to chemotherapy. In some trials, like the Empower 110, already a detrimental effect of efficacy was observed. So this clearly would be a group when I have a high PD-1 expression where I would be a bit cautious to offer these patients an IO monotherapy, I definitely would go for a second NGS testing to see whether there is some hidden oncogenic alteration in this tumor. But I think these are really not the ideal candidates for IO monotherapy. And the second group of patients is a group which is really hard to characterize. So we say, well, these are patients with a high tumor burden. These are patients with highly symptomatic disease. These are patients with fast-growing tumors. This is one of these examples. This is a patient of mine with a tumor on the right central side of the lung. You can see we already had an infiltration of the central airways. We had bulky disease in the mediastinum. We had a high metastatic burden with brain, liver, and bone metastasis. And we had a borderline high PD-L1 expression of 55%. And this clearly are patients where we are a bit cautious to offer them an IO monotherapy as the first approach, because here we really are in need of a fast response. The problem is that we do not have really good marker to characterize these patients. So we really have to rely on our clinical assessment, on our clinical experience. So to summarize my talk, and we had this discussion already 2 years ago at the World Lung Cancer meeting, and this has been the Facebook post of Marina on the 10th of September 2019. This morning man will try to manipulate your brain. And the question is, has anything changed since the World Lung Cancer 2019, one of the last meetings where we could meet in person? I think still IO monotherapy remains an attractive treatment for patients with PD-L1 expression of more than 50%, and we have more confirming data now. We have a confirmed better tolerability. We have a confirmed symptomatic efficacy. We have a confirmed efficacy in difficult subgroups, like patients with squamous cell non-small cell lung cancer, like patients with pretreated brain metastasis. And we have a better confirmation of the signal in long-term overall survival. The problem is that we still do not have prospective trials available for the comparison with the combination of IO chemotherapy, and we still do not have marker available for describing the risky populations. Having said this, I would like to thank you for the kind invitation. And I think in Barcelona at the World Lung Cancer meeting, we had a drink together. I would love to have a drink together with you at some time in person again. Hopefully we will have the chance next year. Thanks for the kind invitation.
Thank you, Professor Reck, for your intriguing presentation. And now let's move on to the next speaker, which is with a great pleasure that I will introduce my mentor and friend, the Professor Marina Chiara Garassino from the University of Chicago. She is the director of the thoracic oncology program in Chicago, and today she will give us her point of view in the combination therapy of in immunotherapy. Unfortunately, probably she wouldn't be able to stay with us till the end of the Congress, so we can make some questions to the end of her presentation. Hi, Marina. It's a pleasure to meet you again.
Hi, everyone. I'm so happy to see you and also to see Martin. We had a lot of fun in WCLC with our presentation, and we still remain friends, although we have a lot of discussion on the best treatment for our patients. And so thank you so much, and I'm very happy to join and to be with you today. So basically, I think that here you have my disclosures, and I think that I use all the time this slide to explain that maybe when we treat the patients with non-small cell lung cancer, it's important to activate the T cell function, but on the other side, it's important also to eliminate the immunosuppressive components like the Tregs, the myeloid suppressor cells, and the M2 macrophages. And we know very well that in the lung cancer, there is a very strong immunosuppressive microenvironment. And I believe that this is the main reason why the chemotherapy works and why we were not able to replace the chemotherapy with other immune checkpoint inhibitors or with other agents. So the reason is that clearly we are able to induce the immunogenic cell death. And so on one side, we are able to activate the activity of the T cells and the T cell penetration. On the other side, as I said, we are able to eliminate the immunosuppressive components. Clearly, this is one of the trial that I was the PI of the trial, and we made a lot of work in Istituto Nazionale dei Tumori when I was there. And this is a randomized clinical trial that you know very well, stage 4, no sensitizing EGFR and ALK alteration, which is different from another trial, which is the Empower 150 trial. PD-L1 was a stratification factor, and it was PD-L1 less than 1% and more than 1%. And the primary endpoint of the trial was the overall survival, and all the other secondary endpoints were progression-free survival, response rate, quality of life, and whatever. This was the first presentation. I think that is still important, not because I want to show all the numbers, but I think that we have to keep in mind some numbers, because this is what we can compare with the 9LA trial. So 69.2% of patients were alive at 1 year, and the median overall survival at the time when the data were presented was not reached yet. Clearly, the trial was statistically significant and became part of our treatment on a daily basis. Here you see the results that we have after a longer follow-up. These are the final results of the Keynote 189 trial, and you can see that there is a drop of the curves with 45.7% of patients alive at 2 years, which is important also to communicate the prognosis to the patients, corresponding to a hazard ratio of 0.57. And please bear in mind these numbers, because I think that can be important to make some considerations at the end. And as you can see here, there is a continuous drop of the curve, and however, the median overall survival of this trial is 22 months, which is higher compared to other trials. This is the subgroup analysis based on PD-L1 expression. You can see that the benefit goes across all the subgroups, and there is a benefit also in PD-L1 less than 1%. This is something that clearly it's an exploratory analysis, and we are making now the guidelines based on subgroup analysis and indirect comparisons. And as Martin said, we lack of direct comparisons of these trials. Also, Charu spoke before about the TMB, and I think that the TMB and in general the ctDNA is very fashionable in the last years, but as you can see here, the TMB, the blood, at least the blood TMB, was not able to dissect the patients who benefit of the chemotherapy or the chemotherapy and immunotherapy. So it can be a nice biomarker for the single agent, but is not a good biomarker to select combination studies. This is the twin trial for the squamous population. there is carbopaclitaxel or nab-paclitaxel added to pembrolizumab in the squamous histology. The concept was very similar, and the results are those with the median overall survival of 17.1 months. The benefit, again, potentially goes across all the subgroup, but there was less benefit in PD-L1 negative in this population. This is the Empower 150. This is a quadruplet, so we have carbotaxol, bev, and atezolizumab. You can see that in this trial also the EGFR and ALK translocated patients were included, and there was a special subgroup analysis for this population. The hazard ratio was 0.78. Also, this trial was positive. The median overall survival was 19.2 months. The median follow-up was pretty good, but I think that at least in Europe, this regimen is not so much used, because in general we don't like the taxane as a first line treatment. And the other peculiarity of this trial is that if we remove the bevacizumab, the hazard ratio becomes negative and corresponding to 0.88. Moving to the most recent part of the chemotherapy immunotherapy, in ESMO earlier this year were presented the results of the Empower Lung 3. Martin showed you before the results of cemiplimab over chemotherapy. Here we have cemiplimab and chemotherapy, which is an investigator choice platinum doublet chemotherapy. And this is what you can see here is that the key eligibility criteria were independent by the histology, so there were non-squamous and squamous. There was any PD-L1 expression, no EGFR and ALK and ROS alterations, and there was also the possibility to have treated clinically stable CNS metastasis. A peculiarity of this trial, as you can see, is that the stage B, the stage 3B and the stage 3C are included in this trial. So I think that this could become relevant in the future, because we do not have really an indication for the bulky stage 3, bulky stage C, and in general we can just do, at least in Italy, we can just do the chemotherapy if they are not resectable and not eligible for radiotherapy. So under these peculiarities, this clearly was a small trial, was conducted in a population where the immunotherapy was not available at the time. And you can see that the results are very, very similar to what we saw in the Keynote 189 trial. The median overall survival was 21.9, corresponding to an hazard ratio of 0.71, which was highly statistically significant again. Of note, you can see that the results starting from the 12 months are very early. There are a lot of censored events. And so I think that this trial is really promising, but we need to have more mature data, because after maybe 16 months, you have a very few patients at risk. And maybe this can be a point for the discussion. I really hope that this new drug will reduce the cost of the immune checkpoint inhibitors for the overall society, and also rendering this drug available for a broader population. The results are very similar also in shape and in numbers to the progression-free survival, and again, they are very similar also for PD-L1 expression. Cemiplimab is not the only one. There are also some other trials combining the chemotherapy with immunotherapy. Camrelizumab is one of them, and you can see that this trial were developed in the Asian population, and the median overall survival again is very promising, 23.7 months, and the progression-free survival was 12.5 months. Results also similar for tislelizumab, and you can see that this was only it's a peculiar trial only for the squamous population. And you can see again, here we have results only for the progression-free survival, but the results were very interesting, again, adding tislelizumab to the combination of carbo-nab-paclitaxel. So I think that the point here is considering that we have multiple trials positive combining chemotherapy and immunotherapy, and without any direct comparisons, we will have to understand how we can use this data, not just for the Asian population, but also for the Western countries, while cemiplimab was a global trial, so potentially is more reliable and more reproducible. Now, Martin spoke about PD-L1 more than 50% already, and she had already presented the results in the plenary session in ESMO earlier this year. And as you can see, this is very important analysis done by Solange Peter of the Flatiron database, but they started from 2,400 patients, and they arrived to the analysis on just 520 patients, meaning that we really don't know if we are selecting a spatial population, but anyway, the results were convincing because they were very similar to what we observed in the clinical practice and in all the previous clinical trials. First of all, there is no difference in the overall population by using the single agent over the combination with chemotherapy. The results, as you can see here from the blue and the red curves, are superimposable. And what is very interesting, I just skip and I move to what Martin already said, is that smoking history plays a very important role. And as we saw also from all the subgroup analysis, is with the monotherapy, the benefit of the single agent is less than the benefit of the combination therapy. Unfortunately, in Italy, it is not reimbursed yet, the possibility to use the chemotherapy, immunotherapy. I think that this is really, it's 2 years that I'm going to say that this is embarrassing. And this is a clear idea that the regulatory agency, they want to say something when the trial was done in a different way. So I think that in Italy, we are losing a lot of possibilities for the patients who never smoked in the past. In the gray area between 1 and 49%, as you can see, again, also Martin showed before the results. This is a meta-analysis of the most important trials, comparing the immunotherapy alone compared to the chemotherapy immunotherapy. And here the results are clear. In the gray area between 1 and 49%, the chemotherapy immunotherapy is always superior to the immunotherapy alone. This can be not a problem in Italy and in Europe in general, because in PD-L1 more than 1%, we don't have a single agent approved, but in the US, you can use also the single agent in PD-L1 more than 1%. There is clearly a subgroup analysis for patients older than 75. Here you can see that the benefit, it seems less, and also for patients who are potentially symptomatic, but the reason is that maybe these patients, they have more comorbidities, and again, in the case mix, we don't have a very clear answer to this phenomenon. Moving to the anti-CTLA-4, and I think that this can be part of the discussion, and I was prepared to do a match 9LA over Keynote 189 with Martin and not single agent and this, so I'm very happy then in the discussion to discuss about this part. This is a very sexy regimen, just 2 cycles of chemotherapy and the maintenance with nivolumab, ipilimumab, compared to 4 cycles of chemotherapy. More or less, the key eligibility criteria were the same as all the other trials. PD-L1 was a stratification factor less than 1% and more than 1%. Clearly, we want to avoid the chemotherapy in our patients. We hate, and the patients hate the chemotherapy. But again, also here you can see that the results were very similar to the Keynote 189, in particular when Martin presented the results in ASCO 2020. But again, there is a drop of the curves with more follow-up, but you can see that there is a sort of plateau, which is about in about 30% of patients with the maintenance of nivolumab and ipilimumab. The results, although we saw many results presented in the three categories, negative 149 and more than 50%, this is the stratification, and you can see that the benefit of the 9LA regimen is independent by PD-L1 expression and has a very similar magnitude of benefit with an hazard ratio of about 0.70. So there was a huge discussion in ASCO where we can use, and we can discuss also today, when we can use the checkmate 9LA instead of other multiple regimens. And Mary Redmond picked this data with an hazard ratio of 0.48 in the squamous population and PD-L1 less than 1%. So clearly, this is an interesting analysis, although this is a subgroup analysis. And so I don't think that this is enough to say that tomorrow morning we have to start to treat these patients with the 9LA regimen, because if you remember, there is a different analysis in the checkmate 227 that we are going to see as soon as possible. These are the results of the Poseidon trial. The Poseidon trial was recently presented. It's a randomized clinical trials comparing chemotherapy over durvalumab single agent, and the quadruplet with durvalumab and tremelimumab. The trial was powered to have comparisons between the red box with the platinum-based chemotherapy and the quadruplet, and the red box over the chemotherapy and durvalumab. The results presented were, I think, not really expected. The trial was negative for the combination with durvalumab, and you can see that the median overall survival was 13.3 months, so really lower than what we saw with the checkmate 189, 407, and 9LA. But the trial was positive when they added the tremelimumab to the trial. But again, you can see that the proportion of patients alive at 2 years is 32.9%. The median overall survival was 14 months. And so, although this is clearly a positive trial, I don't know if there will be a space in this setting where the bar is now so high for the treatment of our patients. One final comment on the 227, which is a very old trial. You know it very well. This is multiple comparisons with the tricky design, but we don't have the time to discuss again this story. But just I want to point out that in 4-year overall survival in PD-L1 more than 1%, the benefit of the addition of ipilimumab is about, if you look at the Kaplan-Meier curves, it seems marginal. It seems in terms of more or less 5 points of absolute benefit. But if you move to the other exploratory analysis, this is in PD-L1 more than 50%, but you remember very well that there was another trial with pembrolizumab and ipilimumab that was totally negative. So again, we don't know if this can add something to PD-L1 more than 50%. And of note, that can be part of our discussion later on, in the squamous population, if you add the if you use just the chemotherapy, nivo-ipi over chemotherapy, it doesn't seem that the ipi is helping so much. That is what we saw in the Kaplan-Meier curves of the 9-LA. So, and finally, I think that although this was a negative trial, it is important to remember that although there was not a standard arm of this trial done by Natasha Leil, durvalumab and tremelimumab over durvalumab, tremelimumab and chemotherapy was a negative trial, although you remember that the progression-free survival was interesting again. So to conclude, I think that my friend Martin said very reasonable things. I think that the monotherapy still has a role, but I think that in the next future we will have to understand for the monotherapy and also for the other agents if we can use pembrolizumab or other compounds. And I think that, as also he said, I think that we need the chemotherapy in PD-L1 more than 50%, in particular in the never smokers. And although the Solange Peters presentation was negative for liver mets and brain mets, I think that was underpowered. And I think that for the most aggressive tumors, maybe we need the chemo because we must exploit as much as possible the benefit of the triplet. But there are still areas of uncertainty. So we don't know how much chemo, we don't know how long we have to continue with the therapy. We don't know if there is a best backbone. And I think that what we clearly know is that the benefit of chemotherapy, immunotherapy is independent by PD-L1 expression, TMB histology. And the work will be to understand where is the right place for the proportion for the anti-CTL4, which is still not unclear. At the time being, I can tell you that after 6 months in Chicago, here we have much more freedom to decide what we want to do. And so I think that is very, very important to discuss the options with the patients in terms of outcomes and also in terms of toxicity. So I can remain here for other more or less 20 minutes. And I'm very happy to see you, and I hope to see you all in person and to celebrate with Martin in person in a Congress. Thank you for your attention.
Marina, thanks for your amazing presentation. We have a question from the audience, from Diego Signorelli. Do you know Diego Signorelli? Okay, the question is, what do you think about the combination of chemotherapy plus immunotherapy in large volumes stage 3 non-small cell lung cancer?
So I think that the results of cemiplimab are very convincing. So there is a benefit for patients stage 3 who are not eligible for resection and also for surgery. I think that it's important to mention a very important effort of Diego Signorelli that you are running in Italy also with Gustave Roussy and Valdebron, which is the bridge trial. There is a chemotherapy, immunotherapy, and the idea is that you can shrinkage the tumor in a lot of patients that in a second part they potentially can become resectable or eligible for radiation therapy. So I think that if the regimen will be approved, this can be the possibility to treat this group of patients, which is not that small, with more modern treatments.
Thank you, Marina. We have time for, I think, 2 other questions.
Maybe also Martin and Charo, if they want to.
Yes, but
jump.
we have to do the round table at the end of the presentation of Roberto. But we can try to. to speak also with Martin and Charles.
So, because we don't have any other questions from the audience, I want to ask you, Marina, in your opinion, why in Poseidon trial the combination of chemotherapy plus durvalumab and tremelimumab gains a clinical benefit in a non-small cell lung cancer, whilst in small cell lung cancer, in the Caspian study, this four-drug combination doesn't reach statistical significance?
So basically, coming back to what I said before, how to use the anti-CTL4 is still unclear. We know that there is a benefit, but there is still unclear. And again, we are comparing trials with a different, maybe also with different patient characteristics, different age, different microenvironment. You saw also that there are results also for the diet that potentially can change the outcomes. Can be the BMI, can be many other factors, and I believe that the case mix of the trials can be not totally superimposable. The populations are not totally superimposable, so I'm not so surprised that the results are different.
Okay, maybe we can have also the opinion of Dr. Reck and Dr. Agarwal.
Probably Dr.
I
Red
think-
doesn't appreciate a four-drug regimen.
Well, I'm working on each kind of regimen, and I think particular now looking on Caspian and the Poseidon trial, we also have to realize that we are talking about two completely different diseases. One is small cell lung cancer, the other one is non-small cell lung cancer. So I think it's quite difficult to compare the trials, the outcome of the trials. And therefore, I also agree with the statement of Marina that we have different trial populations, we have different comorbidities, and it's even difficult to make cross-trial comparisons across non-small cell lung cancer, but then to compare different tumor entities is even more difficult. But my question would be for Marina, and I think you are now 6 months in the United States, and I know that there is a heavy debate about the use of anti-CTL4 in management of non-small cell lung cancer. Sometimes it's also a religious debate whether they add anything on the efficacy of chemoimmunotherapy combination. And what is your impression about schedules like CheckMate 9LA? Is this something which is used in the United States? Or is this just something which has generated some trial data, but it's not coming into real thoracic oncology?
So, well, this is a very good question. So, as you said, I think that there are believers and non-believers in the anti-CTL4, and sometimes it's a religious belief rather than science. And here, I think that compared to Europe, the EP and in general the anti-CTL4 are much more used than in Europe.
Really?
And so I think that there will be the possibility for the 9LA to be part of the treatment. The big problem is that I don't know really who is the right candidate. On one side, I agree with Mary Redman when she said the best part could be for squamous PD-L1 negative, but not because there is a clear benefit there, but just because the benefit of the 407 in the squamous was so poor that if we have to bet somewhere, maybe we can bet on the use of EP instead of the combination therapy. So basically, I think that there is a space. I don't know why after years of research we are not totally able to identify who are the patients who can benefit of EP. And clearly the big question behind the 9LA, and maybe you can answer better than me, is can we use just a short regimen of chemo and then to continue just with an anti-PD-1, or do we need really the anti-CTLA-4? So we tried to, several years ago, we tried with Roberto Ferrara to write a trial with a short regimen of chemo. And we, unfortunately, we were not granted, but my question is, do we really need the anti-CTLA-4? And this is clearly the question also for you, who are the PI of the 9LA.
So I think this is a very practical question, because when I talk to my colleagues who are using the 9LA schedule, the critical problem really is the maintenance with the anti-CTLA-4. And they said, well, the majority of patients, they are getting perhaps 5-6 times than the ipilimumab, and then in the majority of patients, they have to stop. They only can continue with the anti-PD-1. And I think when you look on the treatment intensity in the CheckMate 9LA, this is the same signal. At some point of time, you have to stop the anti-CTLA-4. I do not believe that this is really a continuous treatment, that this is feasible. And I think it's a very reasonable question to ask the necessary dosing of ipilimumab. When we started with ipilimumab, we only delivered 4 doses, and we had the perspectives that we could generate the signal in the memory cells. That the problem has been that we used quite a different dosage in this early trials. This was a very high dose that we gave to our patients. Now we have reduced the dose. We are only using this 1 milligram every 6 weeks. So, but still, in reality, this is an issue. And I have to say the minority of patients are really able to tolerate this ipilimumab for more than half a year or for 9 months. So I think this is a very reasonable approach. And overall, I have to say that we are still lacking the long-term the long-term efficacy data. So even with the 2-year overall survival data of the 9LA, we do not really see that difference in long-term survival. We have to wait because the data are not mature enough. And even for Poseidon, I'm not so sure whether there was this really strong effect on the long-term survival. Still, there were a couple of censored patients in that analysis. So this remains an open question.
Yeah, I agree. And on the other side, in the Keynote 189, for patients who are able to do 2 years of the Keynote 189, you can see a continuous decrease of the renal function. And the question is, do we really need all this pemetrexed? So, or maybe we need just sometimes some shot of pemetrexed, and not every 3 weeks, just to remove the myeloid suppressor components. So yes, I fully agree with you. We have a lot to understand and a lot of debate for our future.
I think this is something which is very much in the focus of thoracic oncology. So when I started, for example, with the early treatment of non-small cell lung cancer, we only gave 4. I have an echo here in my earphones. So we only gave them 4 cycles of chemotherapy, and then we stopped. And then when there was a progression, we reinduced something. So I think this is also a way to move forward, not to have this continuous exposition to certain drugs, which clearly has some toxicity on the patients. Perhaps I have one additional question, and perhaps on both of you, because Cheryl now is also on the line. And this is looking on the role of anti-TIGIT, because there is a lot of rumor that this is the new chemotherapy-free combination. To be honest, I'm still a bit surprised that we haven't seen any survival data on the Cityscape trial. This is the only trial showing a randomized signal with I would say, questionable activity of atezo-mono in this group of high expressors. So what's your prediction? Will this be the new combination for the future?
So maybe for the, so clearly we can't do the science with the press release because
We have only 2 minutes for the opinion of Dr. Gargwal, because at the end we have the presentation of Roberto Ferrara, and we have only half hour of time. Dr. Gargwal.
Yeah, so I think this is a very interesting question that you asked, Dr. Reck. I think some of the data that you've shown with combination CTLA-4 and PD-1 inhibition and in PD-L1 greater than 50% demonstrate really no advantage over pembrolizumab monotherapy on the KEYNOTE-598 trial. So I hesitate to say that, yes, we'll be able to make a breakthrough with compounds such as TIGIT in this category of patients with high PD-L1. I think we'll just have to see. I agree with you that the data with atezo monotherapy for this group of high expressors does seem a little bit less than we would have expected. And I agree with you that we haven't seen any survival data, so it'll be intriguing to see the results. I think it's a very high bar to meet.
Yeah,
So-
particular for PD-L1 more than 50.
So unfortunately, time flies, and we have to proceed with the schedule. So thank you very much, Marina, for your presentation, for the discussion. We hope to see together and continue this meeting on person.
I
In
go
Milano.
the patient. I hope we come back to Milano all together. Bye.
Bye.
Bye, Marina. Bye.
So let's go to the last presentation of this evening. That's a very pleasure for me to introduce my great friend and mentor since when we were younger in 2015 in Verona, Dr. Roberto Ferrara, that now is working with us. And we talk about the mechanism of hyperprogressive disease. So Roberto, the word is yours.
Thank you, Alessandro, for the presentation, for the introduction. Today, my talk will be about mechanism of hyperprogressive disease in patients treated with immune checkpoint blockade. These are my disclosure. So, hyperprogressive disease is a concept that polarizes people. We can say that there are some people who believe that immunotherapy should be administered to cancer patients at one point of the clinical course. And this is because immune checkpoint inhibitor completely change the treatment paradigm of non-small cell lung cancer. And we know that around 30% of non-small cell lung cancer patients treated with pembrolizumab in first line, they are alive at 5 years. On the other hand, the occurrence of fast progression and early mortality upon immune checkpoint blockade has raised an immunoskeptical currents, an immunoskeptical part of clinicians who believe that probably there is an excess of mortality in patients treated with immune checkpoint inhibitor. And the first suspicion of this excess of mortality was seen in CheckMate 057, because it was reported that there were 14 extra deaths in the nivolumab arm compared to the Cetaxel arm in the first 3 months of treatment. So in CheckMate 057, the patients were treated in second line and the third line, and they were not selected according to PD-L1 expression. But in my opinion, the crossing of survival curves is not a question of line and is not a question of biomarker. If we see the survival curves of KEYNOTE-042, that is comparing pembrolizumab to platinum-based chemotherapy in first-line setting, also in PD-L1 over than 50%, you can see a crossing of survival curves at 6 months. Furthermore, if we saw the BFAST trial, non-small cell lung cancer patients with high blood tumor mutational burden, more than 16 mutation megabase, you also can see a crossing of survival curves in the first 6 months of treatment. That means that probably there is an excess of mortality in these patients during the first month of treatment with atezolizumab. But the crossing of survival curves may be a question of treatment type. In fact, in KEYNOTE 189, you can see that the curves, they separate very early and they remain separated for all the duration of the follow-up. And we performed the meta-analysis, including 19 trials, and we tried to understand if the excess of mortality was higher with the treatment with single-agent immune checkpoint inhibitor compared to chemotherapy, and also with the treatment of immune checkpoint inhibitor plus chemotherapy compared to chemotherapy. And what we saw that there was no difference in early mortality using immune checkpoint inhibitor monotherapy compared to chemotherapy, but when we added chemotherapy to immune checkpoint inhibitors, actually there was a significant reduction in the early mortality in the first 3 months. And if we compare these two hazard ratio, 1.05 and 0.83, if we do an indirect comparison, we can say that there was, with the single agent immune checkpoint inhibitor, an increase in the 20% increase in the relative risk of early death with immune single agent compared to immune checkpoint blockade plus chemotherapy. But who are these patients who die very early during immunotherapy treatment? An analysis of Checkmate 057 showed that there are no clinical characteristics that correlate with the early mortality. After an analysis of OAC trial that was comparing atezolizumab versus docetaxel in second-line setting, the authors, they called fast progression patients who experience a RECIST increase more than 50% at first CT scan evaluation during immunotherapy, or mortality within 12 weeks after randomization. And they found that the percentage of fast progression was the same, was 10% in the atezolizumab arm and in the docetaxel arm. And they found also that fast progression correlated with ECOG performance status of 1 and with more than 3 metastatic sites. So they found some clinical characteristic correlating with early mortality. However, in my opinion, early mortality reflects the natural course of lung cancer disease, because also in the chemotherapy era, we know that the mortality rate with first-line platinum-based chemotherapy is there are 30% of patients that cannot receive a second-line regimen, and 40% of patients that cannot receive a third-line regimen, and 50% or more of patients that die during a third-line regimen. This means that probably hyperprogressive disease is something different, is a change in the natural course of lung cancer disease. And in the blue arrow, you can see that there is a disease that has a speed of growth very high before the start of immunotherapy, and also the speed of growth remain very high during immunotherapy treatment. With hyperprogressive disease, there is a change in the speed of growth. So the speed of growth is very low before immunotherapy treatment and start to be high during immunotherapy treatment. Regarding criteria to define hyperprogressive disease, actually, you just have to remember that criteria can be divided in time-dependent criteria and size or clinical-dependent criteria. Time-dependent criteria, they use all of them, they use pre-baseline CT scan. So they need the baseline CT scan before immunotherapy, the CT scan during treatment with immunotherapy, and also the CT scan before the baseline. I will not describe all of these criteria. I will just say that if we considered a tumor with a growth of 2 centimeters each month, or growth of 20% of volume each month, the patients to be considered as a hyperprogressor needs a growth of 40% of volume according to the definition of tumor growth rate ratio, and needs a growth of the diameter of 4 centimeters each month to be defined hyperprogressor according to tumor growth kinetics, and an increase of 70% in the volume each month to be defined as hyperprogressor according to delta tumor growth rate. And then Cato used a composite definition using a mixture of different criteria. Size clinical dependent criteria, they don't use pre-baseline CT scan, and they probably use a composite definition, so they both use a mixture of different criteria. Time-dependent criteria, they have both limitations and strength. The main strength is that these criteria allow the clinician to discriminate, to distinguish between hyperprogressive disease and natural course of the disease. The limitation of these criteria is that new lesions are not considered, no measurable disease is not considered, and some of them, they cannot, these criteria, they cannot be applied if we don't have a pre-baseline CT scan. That means that in first-line settings, sometimes patients, they do not have pre-baseline CT scan and they cannot be assessed with, for hyperprogressive disease according to these criteria. And finally, if we use time-dependent criteria, we run the risk of overestimation of hyperprogressive disease in second and third-line setting, because the tumor growth rate and the tumor growth kinetics in the first-line setting can be very low because patients are treated with a regimen different from immunotherapy. Regarding survival, we can see that time-dependent criteria were assessed in patients treated in phase 1 trial in head and neck cancer patients, and also in a retrospective study including 406 non-small cell lung cancer patients, where hyperprogressive disease was described in 14% of these patients. And there was a delta in survival of 3 months. It means that patients with hyperprogressive disease, they had a median overall survival of 3 months, and patients with conventional disease progression, they had a median overall survival of 6 months. We saw also a limited overlap between hyperprogressive disease and early mortality. In the left part of the slide, you can see that there is the percentage of hyperprogressive disease, fast progression, and early death with the treatment with single-agent immune checkpoint inhibitor. In the right part of the slide, you can see the same proportion in patients treated with single-agent chemotherapy. And as you can see, the proportion of early death and fast progression is almost the same if you use immune checkpoint inhibitor or you use chemotherapy treatment. There is no difference at all, while hyperprogressive disease is 3 times higher if you use immune checkpoint inhibitors compared to chemotherapy alone. And we also try to understand if there is an overlap between early mortality and hyperprogressive disease, and we found that around 40% of patients with early mortality, they also experience hyperprogressive disease. But that means also that 60% of these patients who early die during immunotherapy, they do not develop an hyperprogressive disease. So this is just to say that these two phenomena are probably overlapping, but they are not the same thing, and probably also biologically they are not the same phenomenon. The size-dependent criteria, they use RECIST assessment of tumor diameter at first CT scan, and they also use clinical criteria such as time to treatment failure and worsening of ECOG performance status during immunotherapy treatment. The main limitation is that there is no discrimination between intrinsic aggressive disease and hyperprogressive disease. Furthermore, the clinical criteria such as worsening of ECOG performance status are less reproducible compared to radiological one. There is no inclusion of no measurable disease. The main strengths are that these criteria, they do not need pre-baseline imaging, and so they are easier to be applied in first line, and new lesions are included. According to size-dependent criteria, hyperprogressive disease was found in around 19% of non-small cell lung cancer patients treated with immune checkpoint inhibitor. Again, there was a delta in overall survival of 3 months, with the hyperprogressive disease experiencing a median overall survival of 4 months. And these criteria were applied also in patients treated in phase 1 trial with different cancer type, and again there was a discrimination in overall survival between hyperprogressive disease and conventional disease progression. There are no clear clinical predictors of hyperprogressive disease. I mean that there are several clinical predictor, but most of them, they were just from retrospective study, and so they were not validated in prospective study, and most of these retrospective study, they included heterogeneous population. So it's not, in the clinical practice, we cannot apply some clinical criteria to define the patients that are at higher risk of hyperprogressive disease. Some of them are age or number of metastatic sites or liver mets or even female gender or derived neutrophil lymphocyte ratio. Regarding the potential mechanism of hyperprogressive disease, it is a complex phenomenon, so it needs a complex explanation, and probably there are different players, and probably there is a crosstalk among different players, and players can be from adaptive immunity, from innate immunity, and from tumor itself. Regarding innate immunity and as potential driver of hyperprogressive disease, in this paper it was found that macrophages CD163 positive and PD-L1 positive were abundant in the biopsies from non-small cell lung cancer patients with hyperprogressive disease. And also tumor models, regarding tumor models, it was found that EGFR mutant tumor models, they develop hyperprogressive disease with nivolumab treatment, and the analysis of the tumor showed that the tumor from mice with hyperprogressive disease had a lot of macrophages in the tumor microenvironment. And when it was used clodronate, or clodronate that is an agent that is able to deplete macrophages, or nivolumab without the ability to bind to the Fc gamma receptor, it was found that hyperprogressive disease actually disappeared. So the hypothesis was that the nivolumab with the tail is able to bind to Fc gamma receptor expressed on macrophages, and this binding drives a polarization, an M2 polarization of macrophages. Another possibility is that also that macrophages are able to steal the nivolumab that is binded already to T cells, and so this mechanism avoid the activation of T cells by nivolumab. Other possible immunological mechanism of a hyperprogressive disease that regard innate immunity are probably immature neutrophils, and this analysis we performed on 46 non-small cell lung cancer patients treated with the first-line single-agent pembrolizumab. We found hyperprogressive disease in 9% of these patients, so in 4 patients, and all of them, they had high level of CD10 negative immature neutrophils. We used the CD10 as marker of maturity, and so we saw that in hyperprogressive patients, more than 43% of the neutrophil, of the circulating neutrophil, they had an immature phenotype. And we performed the same analysis also in a cohort of 17 patients treated with pembrolizumab and platinum-based chemotherapy, and we found no hyperprogressive disease, but the fact that the point that we found very interesting was that there were 5 patients with very high level of immature neutrophils. All of these 5 patients, no one developed hyperprogressive disease, and in all of them, chemotherapy was able to reduce the percentage of immature neutrophils. And this was seen also in vitro, because using cisplatin, we saw an increase in the necrotic death, mainly of immature neutrophil. And instead, the mature counterpart, the CD10 positive mature counterpart, did not change with cisplatin treatment. So probably immature neutrophils may be a marker of hyperprogressive disease, and chemotherapy may be a way to prevent hyperprogressive disease, reducing selectively immature neutrophils. T regulatory cells are also probably another player in hyperprogressive disease phenomenon, and this was a paper in gastric cancer patients, and it was found that there was an increase actually in T regulatory cells both in the circulation and in the tumor in the patients who develop hyperprogressive disease. And non-small cell lung cancer patients who develop hyperprogressive disease, they had an increase in the circulation of severely exhausted T cells, TIGIT positive and PD-1 positive T cells. With the French group from Gustave Roussy, we tried also to understand if senescence, T-cell senescence was associated with hyperprogressive disease and with progression to immune checkpoint inhibitor. And we found that using an immunosenescence phenotype, that is loss of CD28 and gain of CD57 and gain of KLRG1, we found that 28% of non-small cell lung cancer patients have this senescence immune phenotype, have more than 40% of T cells with the senescent biomarker. And interestingly, we found also that for patients with hyperprogressive disease, they had very high level of senescence T cell in the circulation. Finally, also tumor cell may have probably a role in the hyperprogressive disease phenomenon. This is a paper in the lymphoma setting. We know that PD-1 on T cells is able also to block some survival signals. So when we give an anti-PD-1, somehow we release the proliferation of these T cells. But this is also probably true, even if there are not a paper published yet, that PD-1 may be expressed by 6 or 10% of lung cancer cell line. So this is just in preclinical models, not in patients. And probably the subgroup of cell line that can express PD-1 can be stem cell line, as was reported in melanoma preclinical models. And so using an anti-PD-1 may somehow induce the proliferation of stem cell that express PD-1. Just a few words on tumor-related biomarker of hyperprogressive disease. In my opinion, these are the curves of BFAST. You see that there is a crossing of survival curves. The patients are selected for blood tumor mutational burden, but these patients probably with high blood tumor mutational burden, they are also the patients with poor prognosis. The median overall survival is just 30 months. It means that probably blood tumor mutational burden, in my opinion, can be also a biomarker to not give immunotherapy single agent, but to give immunotherapy in combination with chemotherapy in order to prevent hyperprogressive disease. And this was also discussed this year at World Cell Lung Cancer Conference, because it was shown that an increase in cell-free DNA and an increase in the variant allele fraction during immunotherapy treatment may predict hyperprogressive disease and early mortality. So when we saw high tumor mutational burden, we should think that there is high tumor burden, and probably chemotherapy and immunotherapy may prevent or avoid hyperprogressive disease. And on the same time, an increase in the cell fraction DNA may be also a mirror of hyperprogressive disease, and we should think to change the treatment type if the patient is on immunotherapy treatment. So, take-home messages: hyperprogressive disease is independent from treatment line and from PD-L1 expression. It is a poor prognostic factor with a median overall survival of 3 months. It is prevented by the addition of platinum-based chemotherapy to immune checkpoint blockade. Several criteria have been published, but there is no clear consensus supported by scientific society and regulatory agency, and this is a big problem, in my opinion. And hyperprogressive disease is a complex phenomenon, and so also needs a complex explanation. Probably multiple players are involved. Biomarkers are needed in order to prevent hyperprogressive disease and also to have the possibility to change early the treatment type. And I would like to thank all the people who worked to HPD topic, mainly people from molecular immunology unit, tumor genomic unit, and thoracic oncology unit.
Thank you, Roberto, for your presentation. Unfortunately, we have only 10 minutes for the questions. Now we check if are there some questions from the audience. Don't be shy.
I will start with the first question to all the presenters. Right now, we have the possibility to administer durvalumab in stage 3 non-small cell lung cancer after chemoradiation therapy. And in the next few months, we can give also atezolizumab in the adjuvant setting. At the relapse of the disease, how much time after the end of immunotherapy could be considered acceptable to restart again the immunotherapy, in your opinion?
Dr. Agarwal first.
So I think the data from Empower 010 is very intriguing, that atezolizumab may benefit a subset of patients in terms of disease-free survival. And we see that this improvement may be higher for patients with high PD-L1 expression. At least on the trial, all these patients did receive adjuvant chemotherapy for 4 cycles prior to starting immunotherapy. So I think coming back to the question, if you ask how long would I wait to start immunotherapy, I would say that at least in the adjuvant setting, I would make sure that these patients receive chemotherapy prior to introduction of immunotherapy. I would not forego chemotherapy. I think this is the same situation in concurrent chemoradiation, where we say that concurrent chemoradiation therapy must be completed prior to initiation of durvalumab in the stage 3 setting. Of course, in that setting, there has been some data to suggest that coming in earlier, even as early as 14 days, may be beneficial. However, I think practically there are limitations in administering it early. In my practice, I try and come in with durvalumab at about 14 to 28 days following completion of concurrent chemoradiation.
Dr. Reck?
Well, I completely agree, but if you are asking for the time you need when the tumor relapses, I think this is still an open question, and clinically, I would say at least 9 to 12 months I would wait before I would re-expose the patient to a checkpoint inhibitor. But this is an assumption. This is a new treatment scenario that we are entering here. We do have these patients in stage 3 receiving durvalumab. They might progress at some time, and then indeed it is the question whether we can re-expose them to a checkpoint inhibitor. Personally, if we have some time without any exposition between 9 to 12 months, I think this should be feasible, but we need additional clinical data.
Thank you.
Roberto?
Don't have any clinical data to give an answer on this topic. I also personally think that there must be at least probably 1 year of treatment-free from the durvalumab, last durvalumab. I don't think that, I believe that probably chemotherapy before could be a good option before giving exposed to get, again, these patients to immune checkpoint blockade. But we need more studies and clinical evidence on this topic.
Thank you. We have time for maybe another question for all the speakers. The question is for Roberto, but I think that also the other 2 speakers can do your opinion. Roberto, what do you think about the possible higher incidence of HPD in patients with non-small cell lung cancer and EGFR mutation? Do you think that it could be too dangerous to use IO monotherapy in these patients in all settings?
Yes, it's a very good question. I think it is dangerous giving immunotherapy to EGFR mutated patients who progressed to EGFR TKI because there is also in the progression probably an increase in the immunosuppressive microenvironment, but also in treatment naive EGFR mutated non-small cell lung cancer, because when EGFR is upregulated, there is a downregulation of HLA and so probably it's, even if it's not detrimental, it's useless activate T cells if you don't have HLA, and so if you are not able to express antigen. Probably it is not, this is just an opinion, but in my opinion it is not possible from a clinical point of view, but from a biological point of view, the best time if you want to think to give immunotherapy to mutated patients, the only window could be from a biological point of view when there is a response to TKI because the microenvironment is activated, the HLA is re-expressed, and there are T cells, less Treg, and so probably is the best moment, but it's not possible from a clinical point of view, also because of the toxicity of giving immune checkpoint inhibitor and the EGFR TKI, and also because you cannot stop an EGFR TKI to give immunotherapy after. But from a biological point of view, probably this could be the best window for immunotherapy. After progression and in treatment naive, I think it's not probably the best setting for immunotherapy. It can be detrimental or it can be useless because there is no HLA.
Dr. Agarwal?
Don't see her.
Maybe we can start with Dr. Reck.
So I agree with Roberto that immunomonotherapy is a difficult thing in patients with EGF receptor mutation. So normally, this is a last line treatment that we offer for our patients, and preferably we are using immunotherapy in combination with chemotherapy or even as a quadruplet in this situation. The interesting part would be whether this is reserved for only for EGF receptor mutation, but also for other oncogenic alterations. So we had a very interesting trial presented this year at ESMO, looking on the consolidation durvalumab in patients with different driver oncogenes. And I think in the most prominent group of patients with ALK, ROS1, or EGFR mutation, there wasn't really any benefit of this consolidation durvalumab. So I think this is not only exclusively seen in patients with EGF receptor mutation, but this also should be investigated in other oncogenic alterations as well.
Dr. Agarwal? Maybe not.
So unfortunately, again, time flies, and now it's the moment of the cocktail. Hopefully, we don't get drunk.
Hello, lovely people. I'm Alberto Catalani, and today I'm your virtual bartender. I'm gonna make for you one drink that is one of the most forgotten cocktail in the world. That is gin and it. Gin and it have 50 ml of London dry gin, like Gordon or Tanqueray, and 50 ml of a good Italian vermouth from Turin. This drink is a twist on gin and French that was made with gin and French vermouth. We put some dash of Angostura bitter to give some bittery note, and then we're going to chill up. We're going to put some ice in the glass. Chill up a bit again. And we pour in the glass. And we're going to garnish with a orange peel. This is the gin and it. You can take some potatoes and salute.
Cheers.
Cheers.
Good Bye.
Bye.
I would like